So the Road to Recover, Rancho levels 6 and 7. These stages are really very wonderful stages. This is when the patient is really no longer being agitated. On a day, like if they had a lot of big activities, a lot of physical challenges the day before and they're tired, remember that brain injured patients regress when they do have problems. They tend to go in the opposite direction. The good thing is that once you get into the 6 and 7 level, they regress to a 5 level. Okay, that's good. A little bit better than regressing down to a 4 level. So moving forward, these are definitely just a much more pleasant. These patients are still different. So if anyone met them, they would be like, there's something not right here with this person. But they can be extremely functional. They actually, with a really solid routine, can go out and participate in the community. They're better, but still impaired attention. Again, bright, shiny thing can quickly, that's right, distract them in all different kinds of directions. But they are capable of learning new skills, which is incredibly wonderful. But as I said, they do have a low frustration tolerance. So if something's really challenging to them, they're going to want to kind of shut down and not do what they need to do. They do still lack insight into their impairment. So a lot of times they don't recognize that this is a shortcoming. I remember a patient that I had who she had a really inappropriate laugh. The way that it sounded, the way that it came off was made you uncomfortable. And, so when she would have people around her, that people didn't want to stay around her because it was kind of uncomfortable and awkward. For people who are typical being around that was very odd. And so she didn't get it. She didn't understand that. And I remember when she started getting up into the 8th, Rancho level 8, how she started having a sense of that, of her laughter being inappropriate. And you could see how she would try to calm it down and actually recognize, I'm laughing kind of out of control. I need to pull it in. So again, you see that as you get into these higher levels. What you love is that increase the time the patient is left unsupervised. They actually can be left alone, which is wonderful. You still want to have a safety room, so if they do get overstimulated, they have a place that they can take themselves to go and have a timeout. And it says here, remove footrests from wheelchairs because, again, impulsivity continues to be a problem. These people are going to want to be able to get around on their own, and if they can, the foot pedals need to be out of the way, and they can foot wheel themselves wherever they want to go. As their attention does improve, you want to increase distractions. So it's okay to have more things in the room. This is when, if the family wants to have pictures of the family and have the gift cards up on the wall, when we hit stage 4, we take all that stuff down. Now they're at this stage, that stuff can go back up on the wall, and it's okay. And in fact, they enjoy it. Everyone enjoys it, and so you can start increasing that kind of things. They will require less cueing at this stage. You can increase the complexity of their tasks. You can incorporate new learning. They start having self-management, and they increase their awareness of others. So really the things you're going to be able to see at the 6 and 7 level are going to be that these patients are capable of, you see them have new learned behaviors, and that you see them starting to have insight into themselves. So, 5, definitely no insight into themselves, quickly regresses to 4. A 6 doesn't really have insight, but as they start having more insight, you're moving more into the 7 category. So again, that's kind of how you differentiate between the 5, the 6, and the 7. Team communication is really important. Consistency is always, this is think about having a teenage child and how important it is to have mom and dad on the same page, because when mom and dad are not on the same page, this type of individual is going to go play one individual off of another. So working with this type of person is like having someone in a 6 or 7 level is like having a teenager. So it's important that everyone be on the same page. Therapists, nurses, doctors, that we all know what's going on, because when the doctor rounds and the patient says, oh, the speech therapist says that I'm allowed to have thin liquids now, and I'm really thirsty, and the doctor says, oh, great, and then gets him a glass of water, and then the speech therapist walks in and is like, what's going on here? And they're starting to do those kind of things. So they're starting to get a little bit trickier, and that's good. We should be happy that they're getting to have more insight and things like that. But that means we've got to up our game, because they're going to, that consistency is going to really be important. Again, routine continues to be an important thing. Really in head injury, that is always the case. Routine is important. So it says the routine is 24 hours to make sure all disciplines, all shifts are doing the same thing, which is really important, that the night shift and the day shift are on the same page, because the patient's going to take the opportunity to challenge all of us and to see if we're all on the same page. At this stage of the game, medication-wise, medications like Ritalin is a really good drug. It does stimulate the reticular activating system, and this may also increase serotonin. The side effect is that it does have central stimulation, which is the fight or flight part of our systems. It may increase or decrease the seizure threshold. So if you start a patient on this medication and all of a sudden they have a seizure, and you had never seen them have a seizure, it may be that they have the potential for seizure, and now that you gave them this was what it took to kind of kick that off. So it's just something to be aware of. I will tell you that we do see Ritalin being given to patients earlier than stages 6 and 7. Sometimes when we have patients at a stage where they're actually in Rancho level 3, we do things to try to increase their awareness and their focus. But we do it at this stage of the game as well, because it actually helps them, they are in these stages like someone who has ADHD. They're very active, they're highly distractible, and sometimes these medications really actually help them focus better and do what it is that they need to get done. And what's nice about these medications is that they have a half-life of only 2.5 hours. So you got to think about that when you're strategizing therapy schedules. But it's also another thing that, depending on how they react to it, it's not like it's in their system for a super long time. Another medication is Cylert, which is has a mechanism of action that we're not exactly clear, like we're not sure what it's stimulating chemically in the brain, but it is similar to Ritalin in its effect. There are less cardiac side effects. Sometimes with some of those other medications, the stimulation can have cardiac effects. It can cause people to have racing in the heart. And that can obviously have its own set of issues. The thing about this medication is that it has a half-life that's 12 hours. So again, that can be wonderful, because to try to help someone who needs help with focusing, this would be a drug that you could give in the morning, would potentially last them all day. So that's just something to think about. Something that I feel like I'm seeing a lot more in clinical practice is amantadine. We see that being used a lot. It's a dopamine agent. It increases dopamine levels. The best results in clinical trials were the use of dopamine agents, but you do have to be careful that it increases blood pressure. But amantadine seems to be a really nice drug. Patients seem to tolerate it well, and it does help them with their ability to focus and to kind of stimulate their mind to be able to do activities and challenges that they have. Bromocriptine is another dopamine agent. As you can tell, this has a little bit different mechanism of interaction in that it does not metabolize into norepinephrine, whereas I think the other one that we had some of that effect. It has been found to be very effective in neglect syndrome. So for the patients who look over to one side of the room, have visual field cuts and don't pay attention to the other side of the room, and then even ignore body parts and don't see them, you can actually give this medication and it helps them have an increased awareness. Oh, I do have a left arm, and oh, I need to pay attention to my left arm, and oh, my left arm's hanging in the wheelchair, in the wheel, and oh gosh, let me grab it and pull it out. They actually start to recognize those other parts of the body. But again, you have to be careful because of it affecting blood pressure and dropping blood pressure. Serotonin agents, Zoloft, Lexapro, Paxil, Prozac, great drugs, really, really great drugs. And what they do is that they can cause you to be sleepy, but they again help you with your ability to focus. These drugs are also medications that we know have help with pain management. These drugs, I mean, the serotonin agents are now being used for all kinds of different things, not just depression, not just anxiety. They really can be very helpful to people. The problem is that they take, this says 7 to 14 days. I would tell you that I've seen it be 14 to 21 days before they actually take their full effect. And so you're going to have to be doing something else while you're getting these medications up to speed. And it says may affect appetite. Again, with some people it may decrease their appetite, but for a lot of people it stimulates their appetite. And so then you have to worry about weight gain. And remember, if you have these patients are impulsive, now they're eating food and now they want to eat food all the time, and so that can be very problematic. So trazodone particularly is a medication that has opposite side effects of the other SSRIs. It does cause drowsiness, and this says give at bedtime to promote the sleep-wake cycle, and you want to give in small doses for mild agitation. So trazodone has some wonderful effects, and it is a great drug to use, but it does cause more drowsiness than some of the other SSRIs. There are also the drugs these are multiple neurotransmitter agents, and that's because they actually affect serotonin levels, dopamine levels, and norepinephrine levels. Each of these do one, and I don't remember which one does which, but you know, one does serotonin and dopamine stimulation, another one maybe does the dopamine norepinephrine, and you have to look for the combination that really does work better for the patient. But remember, this takes 14 to 21 days, so you have to wait that long to see what the effect is. Maybe the effect doesn't look like it's working the way it needs to, so now you got to change over the other medication, and now you're looking at another 14 days before we get there. So that's obviously problematic. These drugs are great drugs, but this is a long-term process to get these in place. And again, they can increase blood pressure and heart rate, and they also can decrease seizure threshold. There are the cyclic antidepressants. The tricyclics are Elavil, nortriptyline, desipramine, are all medications, Remeron. It increases serotonin and norepinephrine. They can be very sedating, so if you're going to use your tricyclic medications, just recognize that they can be very sedating. But they, again, these are specifically some of the ones that are used in pain. I would tell you that I see these drugs used in neuropain all the time, not just this. All of these SSRIs really are becoming very popular in their use for pain medication. And clearly someone who has a brain injury has a reason to have nerve pain problems. I mean, their brain is part of the nervous system, and so this is something that's very helpful to them. MAO inhibitors, it says it increases multiple transmitters. They have a lot of side effects. They have lots of restrictions as far as diet. These are not typically a good drug to use in brain injury. Again, it's one of the many choices that are out there, and maybe you'll have a brain injured patient that really responds well to this, but really in general we would recommend that you not use these medications for brain injury. So what I have here on the last slide is education for discharge, which, you know, ultimately our whole goal is to be able to return these people to their community, if not their community, into an environment where they can have some level of independence, whether that be in a group home type environment, but somewhere where they actually can have somewhat of a lifestyle and life that is independent and gives them the feeling of self-worth that they have that independence. So when you have that kind of thing, know that what's out there are day programs, there are outpatient therapy programs, adult daycare, home health, there's lots of community resources, but in these type environments, recognize that they only are for parts of the day, they're not for the whole day. Group homes obviously are for the whole day, but you go, a lot of these type programs are you go for a certain amount of time and then you come back to another place where you may need to be monitored at that environment. Again, the closer you get to being at a 7 and 8 level, the increased amount of time that they can actually spend time alone. So the other thing that needs to be the last thing that be remembered is that there are support groups. The family needs a support group. The family needs to have a place where they get a break. They may need respite. The patient now may be at a place where they want to go to a support group where they interact with other people similar to themselves who've experienced some of the things they've experienced. And so it's time to actually start looking into that and actually provide them with resources and things to look into when they're out of the hospital or out of the environment that they are in. So remember that safety is always of the utmost. It's always our top thing because these people can really be at risk for doing dangerous things because of their impulsivity, because of sometimes their lack of insight. Sometimes, you know, they get a great idea, it comes into their head and they want to act on it right now. And so there are a lot of things that, you know, if you have someone who used to be able to drive and maybe now driving is not something that they should be doing, leaving the keys to the car just laying around is probably not a good idea, and that they, you know, will want to get in the car and they will try to drive. And so you have to be really careful from a safety perspective. Hopefully we'll have solved some of the continence issues by the time that they would actually be going home, because as I mentioned, incontinence is a leading factor for putting someone back into an institutional environment. Family and friends and the patient need to know how to do transfers, how to do their activities of daily living, because that's all a part of living out in the world, and they need to know how to do it. Sometimes patients' homes have to be modified. You know, if someone's still in a wheelchair, and they have 2 or 3 steps to get in, that's an issue, and you've got to provide a ramp to do that. If all the bedrooms are on the 2nd floor and they're in a wheelchair, then you may need to turn a dining room or something that was an office maybe down on the 1st floor into actually being a room for them to become their new bedroom. Certainly behavior strategies, again, understanding that fatigue and too many challenges are going to cause someone to regress. I think that even happens with all of us. We're not on our best behavior when we're really tired, and brain injury is really no different. The sad part is that their behavior just might be more accentuated. So you just have to be aware of that, and the family needs to be really in tune to that being an issue. So that's it. The next person will be presenting on some more topics in brain injury, and I hope that everything that I've said has been really helpful to you. And if you have any questions, to know that you should reach out to the Brain Injury Association for follow-up.